Hello, thank you very much for listening to the Greenwich Story. I hope you find it interesting. We started in Greenwich about 2.5, it's been running our first phase for 2.5 years already. So we're talking about a project that's been running about 5 years now. So it's got quite a bit of history to it. But we always start off with Sarah's story because we feel it's really important. What we said in Greenwich was, it doesn't matter what we do, how many wonderful systems we have, if it's not a better experience for the patient or the client, then there's really very little reason in doing any of this. So we very much always focused on our population and the outcomes that they got out of the system and how they experienced that. Sarah's a real person in Greenwich, and actually she was really happy with the NHS and social services. She had quite a big package of support. She had quite complex health needs. But what happened was she got referred into our integrated services, and a social worker went out and spoke to her about the problem she was having, but also spoke to her about how life was going, really. And Sarah just said, look, I know you're all working really hard, but I've actually lost my life. I'm tied to this house now because I have so many people coming in to do things for me. I actually lost contact with all my friends and family. So the social worker went back and talked to a team that consisted of social workers, nurses, and therapists, and said, look, can we do this in a different way? Can we look at this? And what actually happened was Sarah had real problems transferring and sort of her mobility and activities of daily living around the house. And the physiotherapist went in there and really looked at upper arm strength and actually getting her to transfer herself. The OT reviewed all the equipment within the property and actually changed a lot of that. And the social worker developed a personal budget that enabled her to get out and about and actually get mobility around the community, to go and see some of her friends and make contact with them. And the simple line I always think was the strongest line I've ever got from a service user. And she said, thank you for giving my life back. She said, I actually feel I've got something worth living for now. And I think that's a really important point, and it's something that runs all the way through all our changes. So we developed a plan in Greenwich, and you'll be grateful to know it looked nothing like that. What we said was that through good engagement with our service users or our patients, but very importantly, our staff who work the system or try to work the system on a daily basis, we would get a good designed system. And from a good designed system, there would be really good outcomes for the people who used it. And we kept that line throughout the model. And in fact, it's transferred now into our phase 2 that we'll talk about later. So we were no different in Greenwich from probably every single person sat here where they work. There was a lot of scepticism amongst our staff. There's some comments there. 2 main real fields. One was, you're just going to move the seats and nothing will change. And the other one was, you're going to I spent 3 years getting this, or longer, getting this qualification, and you're going to remove it from me or make me less of what I really wanted to be. And I can't stress to you how important it was to get that out onto the table, because if they don't get past that, we can't start moving forward. And we did spend quite a bit of time really getting the staff to talk about some of their concerns, their worries, and then we got them designing the pathway. We had really good buy-in by the end of that, both from our commissioners in all organisations and also the staff, and that was really, really important. And we got people to a place where they really were hungry for change and wanted things to be better. That's just one of our teams. You can try and spot the health and the social care worker amongst them if you want. Okay, so what we did, well, the blue flow chart was basically a mantra that we wanted our staff to really understand. We didn't quite go to the point of tattooing them with this, but we came very close. But we felt it was a really important thing for them to understand, and they can all articulate this, as they know everybody in Greenwich who comes into our services, all of them will firstly initial a period of rehabilitation. After that period of rehabilitation, they will either be discharged back into the community completely independent, or they will go on to choice and control. So it was just a very simple sort of way of thinking about it. On the other side of the overhead, you can see the teams that were involved. And we had 6 main areas of teams. There were 3 community assessment rehabilitation teams. There was a joint emergency team. and there was a integrated hospital team. All of those teams have social workers, nurses and therapists in them. There's a single line management structure, so some of them are managed by social workers, some of them are managed by health staff, and then they manage underneath them. So all of that. The thing I'd like to draw out on this really is, I'm going to go through this very, very quickly because I know I haven't got a lot of time, is the JET team. We knew if we could capture people and make our initial contact in the community, we would save a lot of people going through that acute structure. JET became very, very popular with the GPs. What they have is a 2-hour quality standard. Therefore, if a GP, and they're the only profession that have got this facility, they can rapid bleep JET, and we guarantee within 2 hours, JET will be there with the carers and the support the person needs in the community. If that person does need bed-based support, we have access to about 56 beds that we can use as well. They've not missed one of those calls yet, and that has given them a really good credibility within the whole community. They do a really, really brilliant job. Also, we have a nurse in charge of that team, and they manage all our crisis safeguarding, and they do a brilliant job of it, and we have had no issues. So it's very much about sharing of responsibilities and how we work. The other one I'll talk about is the hospital. I'm sure people know that Queen Elizabeth, amongst a number of hospitals, there have been some really big issues around that. We have a new Lewisham Trust now taking over from that. But the hospital was our hotspot. And again, what we did, we really tried hard to take all the bureaucracy. No one in Greenwich gets their destination decided about in hospital. That's how we go. Everything is managed outside. They don't get any personal budgets, nothing. They're pulled through the system and then supported either in the community by our rehab services or by a rehab bed, and the decisions are started to be made then. That's really changed our relationship with the hospital. We've had no delayed discharges with over 65s in Greenwich as yet this year. The only one, I think we have 3 in total, if I remember, and they're all adult mental health, and we're working on that, really trying to bring them into the system. But it's really changed the way we work in Greenwich and the way the hospital system works.
The model in Greenwich has provided a really sound platform for our approach to community-based care. And we were very pleased that we were actually able to make our focus on prevention and early intervention a reality. And pretty early on, we got some really good indicators of outcome measures, which gave us the confidence to know that this was going to work and has carried on working since. And Krishna will talk to you about our next phase in a minute, where we're bringing in other parts of the system. But we just want to sort of flag up some of the things which we know are being achieved. So firstly, in terms of people entering the system, right from day one, we noticed pretty quickly that at least 50% of calls going through the initial contact office were dealt with there and then at that first line contact. And that meant the other 50% were going through to exactly the right team at the right time in the right place. So we eradicated all the duplication. So we didn't have an OT, a physio, a district nurse or a social worker all receiving the same referral for a walking stick or something. So that made a lot of difference. And it meant that we could tap in very easily to the opportunities from choice and control and different ways of working with our social care partners to enable people to be empowered about different choices and decisions they had with their lives. So that was really, really positive. We've also noticed that within the teams that are involved in this integration, we've had a really good retention and recruitment and very, very limited turnover other than actually promotion within the teams or moving around within the teams. And that's, to us, is a fairly good indicator that the staff are happy and they are they really do enjoy working in this way. They feel very valued, and they've certainly enjoyed being part of the decision-making processes about setting up the services. We know that on average, the people who've entered the system and received reablement at home remain at home for longer, and they are independent. And to us, that's a bit of an outcome in terms of ongoing self-management. I don't think we've had, on any month, less than 64% of people ending reablement who have gone on to need any kind of care package. Our impact on A&E admissions and hospital admissions has increased considerably. This just grows each month, mainly through awareness raising about the teams and greater use, particularly by primary care. But we've noticed from sort of the first quarter where we measured to now, it is significantly increasing. In the first year, the biggest impact financially was a £900,000 savings for social care, and that has been sustained. It hasn't continued to drop, it's plateaued, but it hasn't increased. But that's a significant saving just from moving people's seats around and doing things differently. And we have very positive impact in terms of delayed discharges and length of stay when we benchmark and compare to other partners in the system. Now, we can't emphasise enough that this has been achieved through very close working with the people within our organisations. They really are the glue that has held things together. It's teams like these, this is one of our CARS teams, and team managers like this that have actually made it happen. And when people ask us what made it successful, I just think if we could bottle whatever it is they put into it, we'd be millionaires. But they have absolutely put their hearts and souls into making this work, and they really, really believe in it. At regular intervals over the last couple of years, we have met with the staff and given them the opportunities to provide feedback and also to raise issues that aren't working well. Not that we wait to a workshop before we tackle them, but we don't get any negative comments. We just get constructive comments, and we get very good feedback from within the team and outside. We're still not satisfied though, because we have one set of very integrated teams running parallel to various other sets of integrated teams, which I'm sure that will be a kind of familiar picture to many of us. So we want to go from this to this, where it really is seamless around the person at the centre. And we want to evaluate this by using the I statements from National Voices. We really want to know what coordinated care feels like and is experienced by people, right down to the care plan and who to call in an emergency. And it's at this point we are moving now into phase 2, which is bringing on board our primary care colleagues and the wider parts of the system, which also include mental health and learning disability teams as well. What we're trying to do is establish teams around a person so that we can build on the relationships and the culture that we've established and test out further systems. What we want within 3 years' time is a really significant impact on admissions to hospital and residential homes, avoiding them and helping people to have high quality lives at home wherever is possible. So I'll pass over to Krishna, who will talk a little bit about what we're doing in phase 2.
Thanks, Jane. Okay, now we have integrated the social services and the community services, but the most difficult bit is how to integrate or coordinate with the GPs, because GPs are busy, they are doing lots of stuff. We don't have time for this, we don't have time for MDTs, it's just the same old thing, it's all that. That's what we heard, because I'm one of the leads for 12 different practices within Eltham, where this is the phase 2 is being tested and learnt. And none of them would sign up for it initially because it's, again, more work, more bureaucracy. That's what they thought. But then what we did was we put this carrot slide in front of them. So on the left-hand side, what's in it for the GPs? That's how we started. A bit of not the right way to start. It should be the middle one, what's there for patients. But we started with what's there for GPs. So GPs have been moaning about not able to contact their own district nurses, named district nurses who were attached to practices in the past, community matrons. They couldn't get in touch with the COPD matron and discuss a patient when they want to. And lots of other stuff like that. So we said, if you take part in this, you're going to integrate with these people, you're going to have an opportunity to raise things with them, especially for complex patients, where you feel a bit stuck. Because lots of GPs, they say, we have referred them to all these loads of teams and we are case managing them. They can ring us anytime, but we have done everything. We can't do anything more. And still they keep attending A&E, or still the patient is really not well. So what do? We are stuck. And those patients we are going to take on into this Greenwich Coordinated Care project, because it's going to be about complex needs and trying to coordinate the care around the patient and try to improve things. And it's also going to help GPs achieve the care planning direct enhanced services for high-risk patients, because they can do the multidisciplinary team meetings and all and get those ticked off. And it's going to help them with the cough and A&E attendances, and also it's going to bring down the amount of activity, the complex activity within the general practice as well as in A&E and in hospital, because the care is going to be more coordinated and around these patients who have complex needs. And for the patients, if you look at the article from Scotland, there was a patient who had dementia. The carer said she had 108 carers within the last year who visited her. And this is a disaster. It should never happen like that. And especially with the focus on 15 minutes visit and all that, we have to be very careful about all this. So even when I met Jay and Jane from social services and community services, in the implementation group which we have got for this project, I didn't know half of the members, half of the teams which existed as a GP. And that in itself is a very good starting point. I got to know lots of different teams which are there. First thing, who I can get the help from for my patients where I feel stuck. So that's how it starts for the GPs. And then we try to deliver the national goals and in the community, reducing acute hospital activity and A&E attendances. And more importantly, for the patient, it's going to be one person they're going to call if they are in doubt of how to go about things. And it's going to be around them. It's going to involve them. They're going to have a care plan, a very simple care plan with named people, a named lead person who is in charge of their care, and an admin person who they contact if they want to call in somebody or if they're not sure about a wheelchair or something like that. The important bit to remember is, just because a patient with complex needs is part of the coordinated care project, it doesn't mean that they don't get a COPD annual review, which happens every time. It doesn't mean that they don't get a home visit when they have a problem from the GP. All other business carries on as normal. This is just to coordinate their care. So how do we go about it? We have started it already in September now, and we are going to evaluate it in April next year. It's going to run for 6 months, the test and learn. It's a test and learn. We don't call it a pilot because it's a test and learn. As we go along, we meet regularly, and the implementation group gets the feedback from every stakeholder, from the patients as well, and we change as we go along. So high-risk complex patients who have been identified either through the risk profiling, risk stratification tool from the DES, or they don't have to fit the risk stratification tool. The GP can just say, no, they don't have any long-term condition, but I'm stuck with this patient. I think he has got complex needs. His portion or her portion is going to escalate in the next few months, and they're going to get into A&E or something's not right. They can refer it to us. And not just GPs. Majority of the referrals are going to come from the general practice, but any community service person or district nurse or social care, social workers or mental health workers can refer into this service. So what the team looks like, we call it a core team. Basically, it has a lead integration professional, who's the lady who was boxing with that person. We have recruited her, Wendy. She has got a very good clinical background as a nursing background, OT background, and she has been involved with the community assessment and rehab team, where they take in patients with needs. After 6 weeks, they send them back. So it's she's been recruited as the lead person for this project. She's going to have 2 navigators who are, one is from a voluntary background, voluntary sector background, another one from a health background. They are going to be the administrators who will do all the emailing and all that for the multidisciplinary meetings around the patient. So how it works is GPs, other teams identify the patient, do a referral to this core team, to the care navigator, either by email or fax. And then the core navigator will look in that referral form. There'll be a section where the GP would have written, these teams need to be involved in the multidisciplinary team, to be invited, and the reason for referral. This is why I'm referring this patient to this. Once they see that, they email all the teams relevant to that particular patient, to that particular day multidisciplinary team meeting, and they all meet. Once a month, we are planning to hold a meeting. If the GP can't attend, they can attend through a conference call or Skype. This is going to happen like that. Or they can send us a typed input of what they want to be discussed and all that. But we would prefer some sort of an attendance, because that's the basic tenet of this, working together, knowing people, knowing the team members. So once the multidisciplinary team has discussed the patient, the needs and all that, there'll be a very small 2 A4 sheets care plan, Greenwich coordinated care plan, where they will have a named lead professional who is in charge of the care. And then they'll have the contact details of the care navigator as well in the bottom. And then you'll have sections involving, this is the action to be taken, this is the person responsible, this is the time frame, something like that. And a bit of a what are all the problems the patient has got, all the long-term conditions, complex social needs, like a formulation in one bit. This is how the care plan is going to look like. And this care plan, at the end of the MDT, will be uploaded into RIO, which is the Community Services IT, into Social Services IT, and it's a Word document, so it can be loaded into the GP surgery as well, and one copy will be held by the patient as well. So they have the number. If they have a problem, they call the care navigator. They can still call the GP, the COPD team for an SOS call and all that. But if there is a complex need which they don't know what to do, they call the care navigator. Then the care navigator, under the guidance of the integrated lead integrated professional who's Wendy, that lady, they will coordinate the care, so that the patient is not stuck. They're not calling 10 different departments and all that. So that's how it's going to work. So what practical impact? Early identification, shortest path, focus on the whole person, care close to home, around the patient, easy to refer and access services, very flexible, do not get stuck between services, specialist input in the community. And I think I've talked about this slide before, how it will work for GPs. And after we explain all this, all the 12 GP practices in Eltham have signed up to it, because apparently they've been waiting for something like this to happen. That's because there's a lot of shift from secondary care into primary care. They have seen this as a sort of a support. Rather than bashing the GPs all the time, primary care is not pulling their weight, primary care is not doing this, primary care is not doing that. We'll give you some support. You do your job. That's what this is all meant to do. And then good engagement, design, and great outcomes.